All right, welcome everybody to our October culinary medicine seminar. Tonight's topic is navigating the intersection of celiac disease and type 1 diabetes. And we have an amazing group of speakers here tonight to lead the program. Our moderator for tonight is Megan Donnelly, who is our Director of Health Communications here at the Celiac Disease Foundation. And I'm going to turn it over to Megan to lead tonight's webinar. As many of you can see, I'm not at home. I'm actually on the celiac cruise on the Danube. And so Megan is going to take it from here to make sure that we have no technical glitches. So Megan, it's all yours.
All right. Hello, everyone. Thank you so much for joining us. So today's topic is going to be about navigating the intersection of celiac disease and type 1 diabetes. This program is accredited for a CEU for dietitians and physicians. In order to obtain your CEU, you're going to have to take a post survey, which I will show you the link for in a second. We want to say thank you to SHAR for sponsoring this very important program. They've been an avid supporter of culinary medicine from the beginning, and we're very grateful for their support. And here is more information for the CEU credits. So once again, you will need to fill out a post-event survey, which there will be links for at the end of the presentation. All right, and here are our lovely speakers for today. So I will let each speaker kind of introduce themselves, but we have Mary Scholl, who's a gastroenterologist from Children's Hospital of Colorado, and Sharon Weston, who is a registered dietitian at Boston Children's Hospital in the endocrine and digestive disease clinic. So we are very grateful to have them. And Mary, I will turn it over to you.
Perfect. Thank you. And thank you, everybody, for joining us. We're really excited about this very important topic. And I think we have a really great group of speakers today. Okay, let me share my screen. Okay. Okay. Did that work, I think?
Yep, looks good.
Okay, perfect. All right. So my name is Mary Scholl. I'm a pediatric gastroenterologist at Children's Hospital Colorado. So I see a lot of patients with celiac disease and also celiac disease and type 1 diabetes. And I wanted to introduce the kind of concept of this dual diagnosis today. So no disclosures or anything conflicts of interest to report for me. And so I think this is something that everybody probably on this call already knows, but I wanted to start a little bit with what is celiac disease. And so celiac disease is an autoimmune enteropathy. So that means it affects the villi of your small intestines, which are these little finger-like projections that kind of stick up and give a big surface area for you to absorb all of your nutrients, as well as most of the water and electrolytes in your body. And so when you don't have celiac disease, you have these nice tall villi standing up, able to absorb your nutrients. When you do have celiac disease, then your immune system gets confused. It attacks the villi, thinks it's a foreign invader like a virus or a bacteria, and then it makes them shrink down and get flat like this. And the trigger for celiac disease is very clearly gluten. And gluten is a protein that is found in wheat, rye, and barley, as well as oats when they're contaminated, which is unfortunately a common problem, that there could be cross-contamination from using the same equipment in processing or growing oats. So that is what gluten is. And for somebody with celiac disease, it triggers this autoimmune cascade that can cause really significant problems. Celiac disease is relatively common. It's found in about 1 to 3% of the population worldwide, including in the United States. And it can have a really variable presentation. So some people with celiac disease have what we call classic celiac disease. And typically, when we think of classic celiac disease symptoms, patients have diarrhea, abdominal pain, they can get bloating, distension. A lot of times we see this in really young kids, especially in the toddler age, 1 or 2-year-old, and we can see poor weight gain, poor growth. We call it failure to thrive. Sometimes patients have a personality change and are very irritable, fussy. That's kind of the classic celiac disease presentation. But more recently, there's actually more patients with celiac disease who are having what we call non-classic celiac disease symptoms. And some of these to highlight here are brain fog, fatigue, headaches, including migraine headaches, sometimes constipation instead of diarrhea. You can get teeth issues, this thing called dental enamel hypoplasia, sores in your mouth. There's actually over 250 different symptoms of celiac disease, and each patient kind of has their own flavor of different celiac symptoms. So it's a disease that, because it can be so variable, we all need to have a really high degree of suspicion for it and look for it to be able to know that somebody could have celiac disease. There's also patients who have celiac disease, but are what we call asymptomatic or subclinical celiac disease. So they really don't have any of these symptoms, classic celiac symptoms or any at all. And this can be a little bit tricky because how do we know how to find these patients is something I'll talk about in a few minutes. Also because some of these patients may see less of a reason to follow the gluten-free diet, which we'll also talk about. For celiac disease, right now, the only current treatment is a strict lifelong gluten-free diet. And so that is, as I'm sure many or all of the people on this webinar know, a big challenge because even 1 crumb of gluten in the form of cross-contamination can cause problems in somebody with celiac disease and make their villi go from nice and tall when you're eating gluten-free to flat like this. So there's a lot of different medications in the research works, but not available right now. And the gluten-free diet is challenging in many ways. First, it's expensive. So gluten-free foods cost on average at least 2 to 3 times more. Some studies even show it's up to 10 times or some even 17 times more on average than the regular gluten-containing counterparts. So it's expensive. You really need to plan ahead to eat gluten-free and to have food at all different situations at home and away from home. And then you really need to be constantly vigilant and looking for even those hidden gluten sources and even crumbs of gluten that could cause big problems. So that makes things like restaurants, travel, especially challenging, but things even like just being at home can also be difficult too. And so what is type 1 diabetes? Type 1 diabetes is also an autoimmune disease, like celiac disease. And instead of the small intestines and the villi of the small intestines being affected, it's these beta cells of the pancreas that are affected and destroyed by your immune system. So the beta cells are important because they produce insulin, which controls the glucose or sugar that's in your blood. And so when you have type 1 diabetes and the beta cells get destroyed, you aren't able to make insulin, which can cause a lot of problems. So type 1 diabetes is less common than celiac disease. It's about 0.25% of all youth, kids and adults. There is typically a very long pre-symptomatic phase, which is months or even in many cases seems to be years, where the pancreas is getting destroyed like little by little, but it's not until often around 80 or 90% of those islet cells and beta cells are destroyed that you don't have enough insulin that you get symptoms of celiac disease, or sorry, of type 1 diabetes. And then those symptoms of type 1 diabetes most commonly are weight loss, sometimes fatigue, low energy. Patients can be really thirsty, needing to pee really, really frequently. Sometimes we see new bedwetting as an early symptom in a kid who has been potty trained, including overnight. That is a new symptom, can be suspicious for type 1 diabetes. And sometimes you can have a fruity smell of the breath. Most commonly, type 1 diabetes is diagnosed in children and teenagers, so not in adulthood, although there are more people being diagnosed with type 1 diabetes in adulthood. And the only treatment right now is needing to be given insulin, exogenous, so not made by your body. And there's a lot of different forms of this. There's long-acting, short-acting. Fortunately, there's a lot of different ways we can give it. There's insulin pumps and things like that. But insulin is right now the only treatment, although there are newer studies suggesting that things like a transplant of pancreatic islet cells into somebody who's type 1 diabetic's body can actually allow them to make insulin themselves. So there's some really exciting things that are sort of just newly starting. And then another exciting new development in type 1 diabetes is this newer medicine, teplizumab. It's a monoclonal antibody, and if there's a patient who's in this long pre-symptomatic phase, they don't have any symptoms, but we know that they have multiple antibodies to type 1 diabetes, and we know that this process is happening. We're able to, in some cases, start them on this treatment that can help delay onset of type 1 diabetes by an average of 2 years, sometimes more. Now, it's a very expensive treatment. It costs about $200,000 per patient. And so obviously it's not something that is sort of routinely started except in significant, specific circumstances, but it's a really exciting intervention. So some of the challenges with type 1 diabetes include, to monitor your glucose and then inject your insulin. That means a lot of pokes. And so a lot of finger pokes to monitor glucose, a lot of pokes in the tummy or arm or legs or bottom to give the insulin. Fortunately, there are more things that make this a little bit easier these days, things like a continuous glucose monitor or an insulin pump, but it's still a big burden for the kids. Also, we need to adjust how much insulin you need based on how many carbohydrates you're eating in a day and actually in each meal or snack. And so it's really important for the patient and family to count the carbs and adjust their insulin dose accordingly. And then when we're trying to aim for this sort of in the middle amount of insulin so that our glucose is, right where we want it to be, but it's hard. And sometimes when you're dosing a child and you think they're going to eat X amount of carbs, but they eat 1/4 of what's on their plate, you gave them too much insulin and they can go low. If you don't give enough, they can go high. And both being too high or too low with your glucose frequently long-term can have symptoms and complications with each. So there's a lot of similarities between celiac disease and type 1 diabetes. One of the sort of big obvious ones is that they're both autoimmune diseases. And so both of them involve your immune system kind of going haywire and attacking a part of your body, which is not very helpful. And that it's specifically T cells of the immune system that cause this damage to happen. Both of these have been seeing in the last 30, 40, 50 years a rising incidence and prevalence. So number of people diagnosed per year and number of people who have had this chronically in the population, especially in the developed countries, higher income countries. And there's a lot of thoughts about why that could be. Bottom line is we're not 100% sure, but both are increasing. Both have autoantibodies in the blood that we can test to screen for these and to monitor them. The TTG-IgA is the one that people know for celiac disease, but there's other ones as well. And there's 4 main ones for type 1 diabetes. And then there's some shared genetics of celiac disease and type 1 diabetes. So in order to have celiac disease, you essentially have to have HLA-DQ2 or HLA-DQ8 genes. So if you don't have those genes, it's pretty much 0% chance that you could ever have celiac disease or that you have it now. However, having HLA-DQ2 or DQ8 gene alone is not mean that you have celiac now or that you ever will. So if we look at this big circle as all the people in the United States, About 40% of those people have HLA DQ2 or DQ8. That means they could get celiac disease. But the amount of people who do get celiac in their lifetime are the smallest circle, the dark greenish blue, and that's only about 1 to 3% of all people. So there's many people who have the genes where they could get celiac, but don't ever. And then for type 1 diabetes, most people with type 1 diabetes have the HLA-DQ8 gene. And so they could get celiac disease and diabetes both. So the dual diagnoses of having both celiac disease and type 1, typically what we see is almost always type 1 diabetes is diagnosed first, and then celiac disease is diagnosed second. Almost always that's the order that it happens. Occasionally it'll happen that you have celiac disease and later get type 1 diabetes, but typically the sort of autoimmune storm of type 1 diabetes is so significant that it often would trigger the celiac disease to happen around that same time. And when we look at the group of all people who have type 1 diabetes, about 5 to 10% of that group will later develop celiac disease. But when we look at the group of all people with celiac disease, only about 1% or even a little less are later diagnosed with type 1 diabetes. So usually it's diabetes first, celiac disease second. Another thing that's different about patients who have both celiac disease and type 1 diabetes is that it's a little more common for those who have both conditions to initially be asymptomatic or have what we call the subclinical presentation rather than have those significant symptoms of diarrhea, abdominal pain, bloating, that kind of thing. In one Canadian study from 2022 looking at pediatric patients, in their group of patients, those who had both type 1 diabetes and celiac disease, about 27% or almost a third of them had no symptoms from the celiac disease or with gluten exposures, compared to in that group about 7% were asymptomatic if they only had celiac disease. And a big part of why you're more likely to be asymptomatic when you have type 1 diabetes and celiac is because of screening. And so traditionally, when we're looking for people with celiac disease or type 1 diabetes, we do what's called case finding. So if you come in with symptoms of one of these two conditions, we do the testing for it and see if you have it. Or if you have risk factors, that's a time to screen. And so some risk factors will be if you have a family member with celiac disease, you have about a 10 to 15% chance of also having celiac disease if it's a first-degree family member. If you have other associated autoimmune diseases, that includes type 1 diabetes, you're more likely to have celiac. Or if you have other conditions such as Down syndrome or trisomy 21, you're more likely to have celiac disease. And so these are situations where we screen people routinely. And there's not great guidelines, but typically when someone is diagnosed with type 1 diabetes, also, we screen for celiac disease right at the beginning, and then we rescreen if they're negative, negative TTG-IgA. We rescreen them every 1 to 2 years, sooner if they're having symptoms. There are times that patients can have high celiac antibodies at the time of diagnosis of diabetes, but they actually don't have celiac disease. So there are cases where early on we'll kind of watch and wait, we call it. We'll have them continue gluten in their diet. We'll monitor symptoms and growth and antibodies over time. And there are patients who have high levels of celiac antibodies when newly diagnosed with diabetes, and then they go away and they don't end up having celiac disease. And so if we screen everybody in the population, which is something that a lot of people think about. If we screened everybody, it could mean that you're diagnosed sooner with celiac disease or type 1 diabetes. That might mean that you're less symptomatic. This is particularly good in type 1 diabetics, where they can often be really sick when they present. So they can have diabetic ketoacidosis or DKA, be extremely ill in the ICU. And if we could diagnose people when they are minimally symptomatic or asymptomatic, that's obviously much better. Actually, last fall, Italy passed a law which mandates nationwide screening for all kids age 1 to 17 for both type 1 diabetes and celiac disease. This is something that they're going to do at ages 2, 6, and 10 years old. This year, they're in the pilot phase of this. They have 4 different sites that they've started this on. And then early in 2025, they're going to start this nationwide. And that's because of catching patients earlier usually means better outcomes for patients. In the United States, I just wanted to give a quick plug. Clinically, it's often very difficult to send the type 1 diabetes autoantibodies. They're sort of unusual tests to send and very expensive. But this is a plug for the ASK study, which is autoimmune screening for kids. It's at the Barbara Davis Center, which is associated with Children's Hospital Colorado, which is where I work. And it's a test that initially we started the screening in kids in Colorado and have screened over 30,000 kids for type 1 diabetes and celiac disease both. And we've expanded recently in the past few years to now be nationwide. So they can actually send you a kit that you can diagnose. You can, do the blood stick yourself with a little kit and send it back in. So askhealth.org, if anyone is interested in that, is where you can learn more information. And you can be in that if you have known diabetes or celiac already. Okay, so what if I don't have symptoms and I don't want to know that I have these conditions? So there are risks of both untreated celiac disease and untreated or poorly treated, poorly controlled type 1 diabetes. So for celiac disease, the biggest ones are malnutrition and poor growth. We also see problems with osteoporosis or poor bone health. Kids can have more broken bones or fractures. Anemia and nutrient deficiencies can be a problem, and we can see increased risk of infertility and miscarriage. And then, unfortunately, but rarely, we can see problems with different kinds of lymphoma or cancer in patients with long-term untreated celiac disease. And then with type 1 diabetes that isn't being controlled, the DKA or the very severe presentation that I talked about can happen, which can result in hospitalizations. You could be in a coma, you could even die from this. So it's quite serious. You can also have malnutrition and poor growth. You can also have bone problems, as well as neuropathy or problems with your nerve, kidney disease, eye disease, and different heart and vascular disease from diabetes. Okay, so what are the benefits of diagnosing and treating both type 1 diabetes and celiac? The biggest one that we see tends to be improvement in weight gain and growth. And I find in many of my patients who seem to be asymptomatic or subclinical and have type 1 diabetes, they do have sometimes pretty subtle decrease in their weight gain and growth that does improve significantly after starting a gluten-free diet for celiac disease. Perhaps improved bone mineral density, although the data is a little bit mixed on that. So really more studies need to be shown. There's not great evidence that if you start the gluten-free diet and you're already type 1 diabetic, that it's going to, improve your diabetes control or give you a lower hemoglobin A1C. The data is a little bit mixed. And the data on the impact of other complications like the diabetic retinopathy or eye disease is a little mixed too. So some suggest that you are less likely to have eye disease if you have both and you're on the gluten-free diet. Others suggest you might be a little more likely to have kidney disease or the eye disease or peripheral nerve disease if you have both type 1 diabetes and celiac. So really mixed, not a lot of data to know exactly what the effect is on some of these complications. There is some data that suggests when you start the gluten-free diet for your celiac disease, whether or not you have type 1 diabetes, that may decrease your risk of later getting other autoimmune diseases like autoimmune thyroid disease, Hashimoto's or Graves' disease, other conditions like that. And of course, and this is what the rest of our speakers are going to talk about as well, there are more challenges to the gluten-free diet when you're diabetic. And so, there's fewer options to choose from, right? And so sometimes if you have celiac disease, you have to eat gluten-free. You don't have multiple options, you have one option, and that option may have a ton of carbs. And that means you need more insulin. We have to do a little bit more to kind of correct that. There's more patients, like I talked about before, who are asymptomatic or minimally symptomatic if they have both type 1 diabetes and celiac, so they may be a little less motivated to understand why I need to do yet another thing and a really hard thing of following the gluten-free diet strictly. Although, some studies suggest, most studies where they've looked at this suggest that patients who have just celiac or celiac and type 1 diabetes tend to do an equally good job of kind of sticking to and adhering to the gluten-free diet. Some other studies suggest there may be more barriers to the patients who have diabetes and celiac in terms of the social pressures, restaurants, problems with school that patients just with celiac disease also face. But more research really needs to be done on this area. It's something we all hear about from our patients for sure. And then the burden at school too with 504 plans. Okay, so I have a lot of references on here. Happy to take any questions, but I think we're gonna save them at the end and let everybody else kind of keep talking. Thank you. Sorry, I could talk all day about this.
Thank you so much. Yes, so everyone, please put your questions in the chat throughout the presentations, and we will try to get to as many as we can at the end. And with that, Sharon, I will turn it over to you.
All right, thank you, Dr. Schall, for covering all of that comprehensive information on the medical part of the dual diagnosis. I'm just gonna have you stop sharing your screen and then I'll share mine.
I think I did, hopefully successfully now.
That's not quite. It's saying the host isn't allowing multiple presenters to share.
What do you see, Megan?
Yeah, we still see your PowerPoint reference page, but it's not in presenter mode.
That's super weird because oh, here's another place.
Awesome.
Okay, now? Okay, sorry.
Thank you. All right. So these are my disclosures, and I'm going to be talking about the dietary aspects of the dual diagnosis, and none of these create a conflict of interest for today's talk. So my objectives, and first of all, I should say, by the way, I'm Sharon Weston. I'm a pediatric dietitian at Boston Children's Hospital, and I work with patients who have celiac disease on the GI team for celiac disease, and then I also am working in the endocrine department, working with patients with type 1 diabetes. So it's great to be able to work with both diagnoses and serve our patients with a dual diagnosis. So my objectives are to describe the role of the dietitian working with patients with celiac disease and type 1 diabetes. I will review glycemic index of foods and strategies to optimize glycemic control on a gluten-free diet at home and also at school, and review benefits of culinary medicine in relation to the dual diagnosis and provide some resources too. So first off, just talking about the role of the dietitian as part of the multidisciplinary team. Really, the dietitian is that link between endocrine and gastroenterology. And so our job is really to provide nutrition education regarding the gluten-free diet, but also in the context of glycemic control. From a GI perspective, really our role is to instruct on food labeling, label reading, also detect hidden sources of gluten, assess growth, really ensure micronutrient intake and nutritional adequacy are met. From the endocrine side of things, we're really helping to assess macronutrient intake, so talking about carbs, protein, and fat, looking at glycemic trends at meal and also snack times, and relating blood glucose trends to diet, and also just trying to work with insulin dosing regimens to optimize things. The nutritional goals for pediatric patients with type 1 diabetes and celiac disease that we really want to try to work on are really to first off maintain optimal blood glucose control, also really help to adhere to a gluten-free diet for celiac disease management. We know that is the only current treatment for celiac disease. Also to ensure adequate nutrient intake for growth and development, and provide support to our families for meal planning and social activities, and really just general life, right? So gluten-free foods, we know, can impact blood glucose levels in very unexpected ways. Patients with the dual diagnosis may exhibit irregular blood glucose levels, not only due to differences in the glycemic index of gluten-free foods, but also gluten-free foods tend to sometimes have higher carbohydrate contents compared to their gluten-containing counterparts. And then we also have to think about, especially in newly diagnosed patients who may have had some damage to their gut, this could impact absorption, and you may see inconsistent highs and also low blood glucose levels due to just their gut integrity. So one day they may have a normal glycemic response to a food, and the next day have a hyperglycemic response to the same exact food. So it doesn't quite make sense. I like to really use this slide to just talk about the impact of different food fuel circles on blood glucose levels over time, and just help our patients understand how the different macronutrients and fiber and sugar and carb, protein, fat really affect blood glucose levels. So looking at the first food fuel circle, which consists of more high glycemic carbohydrates, you see that you have that rapid rise in blood sugar, insulin goes to work, and then if you're just consuming these more empty carbohydrates, you might have a rapid drop in blood sugar. Whereas if you compare the second circle of food fuel with more higher fiber, lower sugar carbohydrates, you have a more gradual rise, lower peak, more gradual fall in blood sugar, but it's still a roller coaster because those are all carbohydrate types of foods. And it's not really until you bring in protein and or fat combined with those higher fiber, lower sugar carbohydrate foods that you have this nice, even, long-lasting food fuel that is more helpful with controlling hunger, energy levels, mood, and just a better source of food fuel. So gluten-free products can contain many different types of gluten-free ingredients. And one of these studies that I'm showing here was a review study that looked at 18 different studies evaluating gluten-free breads, totaling 132 bread samples. And the results of this review showed that about 60% of samples presented with high glycemic indexes versus only 18% were classified as low glycemic. And you can see on the left in green, flours or ingredients that are going to tend to have a more low to moderate glycemic response are going to come from things that are more nut flours or seed flours or even legume-based flours, things like almond flour or quinoa flour or flakes, versus things on the right in red, which are more going to have a higher glycemic response, things like white rice flour or even buckwheat flour. This study also looked at the impact of different types of ingredients that can show up in gluten-free foods. And you'll see many different ingredients that try to help create what that gluten-containing food would taste like, and also the characteristics of not crumbling apart and falling apart, right? So a lot of times you'll see things like proteins and pectins and gums and extra fibers. And what the review study showed was that when you have extra things like fiber or yogurt or cottage cheese, sourdough, things like psyllium or fructans or even resistant starch, that can actually reduce the glycemic response. So the bottom line is to really like inform our patients and families on blood glucose trends and look at different ingredients and notice when they're comparing even things like a 1-to-1 gluten-free flour that different products can have different ingredients and those might create different responses. So understanding ingredients and comparing them to blood glucose trends can be helpful. And this chart just kind of helps educate our patients on which carbohydrates fall into which categories. So we get our carbohydrates from things like vegetables, fruits, legumes, grains, snacks, sweets, and beverages. In the lower glycemic response carbohydrates, we're going to have things like non-starchy vegetables, fruits like berries, legumes. In the moderate glycemic category, we'll have things more like winter squash or tropical or processed fruits, or less processed, higher fiber grains that have lower sugar contents like gluten-free oatmeal. And then in the high glycemic category would be things like white potatoes or juice or refined grains that have maybe more sugar or even just highly refined. So things like white sticky rice or things like sugary cereals with more than 6 grams of sugar per serving. We also want to remember that protein and fats are going to relate to our glycemic response as well. And some protein foods can be high glycemic, things that have more sugar content, things like sugary yogurts or sugar like flavored milks, or even highly processed breaded things like gluten-free chicken nuggets, versus our protein foods, which are going to reduce the rapid rise in blood sugar, such as things from dairy or meat or chicken or even fish. And then our fats would come from things like nuts and seeds and dressings and spreads. And also thinking about increasing awareness of healthy protein sources and fat sources that come more from plant-forward diets, to really encourage wellness from those things like a Mediterranean-style plant-forward diet approach. So in general, a low glycemic gluten-free diet is going to emphasize minimally processed foods, lean proteins, dairy, nuts and seeds and legumes and non-starchy vegetables, lower glycemic fruits, and then whole grains, which are gluten-free. Our main messages for nutrition are really to try to focus on eating balanced meals, also choosing gluten-free paired snacks, including a variety of foods, also being aware that protein and fat can impact blood glucose levels, as well as different varieties of gluten-free grains, and then also remembering that those different ingredients, those fiber additives or gums, may also impact blood glucose levels. The gluten-free balanced plate model is really an easy visual to help with meal planning. I like to think of it in steps. So step 1, pick your fruit or vegetable. Step 2, pick your gluten-free carbs. Step 3, pick your protein. And step 4, add your healthy fat. And it really doesn't have to be complicated to create a balanced meal. Planning meals and snacks ahead is really going to be a key element to success and really can help minimize frustration, especially for busy families. Also, just thinking about paired snacks is also very helpful for helping optimize glycemic control. And so paired snacks are really going to, again, provide that even food fuel to our bodies. They can act as a bridge between 2 meals, so that can help prevent lows from happening or just even satisfy hunger. And again, we want to think about eating snacks mindfully. So thinking about sitting down, slowing down, savoring every bite, simplifying our environment by turning off electronics, and smiling in between bites are just great ways to think about mindful eating. When you choose something from the first column and pair it with something from the second column in this table, that creates a paired snack. So for example, it could be as simple as an apple and a piece of cheese. Sometimes we also need to think about gluten-free snacks that are low in carbohydrates, and this may be helpful during the school day or in a situation where you just don't want to provide insulin in a significant amount. So these could include things like turkey pepperoni or jerky or meat sticks, olives, dried seaweed snacks, cheese and nuts, and different kinds of seeds, pickles, hard-boiled eggs or egg muffins that don't include any grains, veggies with hummus, ham and cream cheese pinwheels, edamame, Parmesan cheese crisps, or even cucumber with avocado or guacamole dip. We also need to think about some gluten-free snack ideas that might need to provide carbohydrates, so treating a low or preventing a low. So obviously we could use our glucose tabs or juice or gummies, but it's also important to think about having some easy to carry snacks on hand just as that backup source. So having a gluten-free bar or some nuts or some gluten-free crackers handy, carrying or keeping a jar of sun butter or peanut butter in your backpack or in the car with a plastic spoon. You can get dried or roasted edamame now in little packages, or even having like a protein shake that is shelf stable until it's open are just some good options to think about. And also keeping a doctor's note on hand to allow for carrying those necessary food items when you're traveling or even when you're going to a different event. So something like if you're going on a flight or going to a concert or going to a sports game, that might be very helpful. And we also want to think about strategies for insulin coverage. So especially with higher glycemic, gluten-free foods, and this especially seems important in the morning at breakfast time for many patients. Pre-bolusing insulin can be really key. So having that insulin on board 15 or even possibly 20 minutes before eating can really help with managing that blood sugar high. Sometimes that's really difficult, and it's really helpful to work with our patients to come up with strategies, like maybe you get up out of bed and while you're brushing your teeth, you're entering your carbs into your pump. But that early administration of insulin can really sometimes help with managing those highs. May also need to modify the delivery mode if you're in manual mode with your pump, and doing things that are creative, like using extended or dual waves or even a temporary basal, can sometimes help with just these different types of food fuels that we're providing that are gluten-free, and also paying attention to covering protein and fat, especially in meals that are either very high in protein or fat or very low in carbohydrates and have some protein. You may need to take those into account. So working with your endocrine team to just optimize insulin delivery options is important. Also want to talk just a little about meal planning tips first at home. So again, planning meals and snacks ahead is a really key element to creating success and minimizing frustration. And so some families may choose to go 100% gluten-free in the household, or some families might do a combination, but it's always important to reduce that risk of cross-contamination, which we know can be just as small as 10 milligrams of gluten, but 10 to 50 milligrams is usually what's thought of for cross-contamination. And that could be just as small as 1/70th of a piece of regular bread. So preparing the gluten-free recipe first, and then the gluten-containing recipe second, going to really be helpful for minimizing cross-contamination, as well as thinking of other strategies that just keep the kitchen clean and keep work surfaces clean and things like that. Taking advantage of naturally gluten-free foods, things like your fruits and vegetables, and things like corn as a starch or sweet potatoes are really easy to minimize cross-contamination, as well as just keep things simple. And then paying attention to those different glycemic responses in ingredients can also help optimize blood sugar control. So just varying the type of flour that you use in a cookie recipe can be very helpful. Finally, we also encourage batch cooking, because that, cooking a double batch can just create leftovers that you can then freeze, and then taking that out of the freezer is so much easier than not knowing what to do for a quick meal. We also want to talk about meal planning tips at school as well. So again, keeping things simple, keeping to that balanced plate concept of step 1, fruit or vegetable, step 2, protein, step 3, carbs, step 4, fats, can make a balanced meal for packing a lunch very simple and well valued with nutrition. But we also want to think about the containers that we're packing our lunch in. So creating a special container that's like a bento box is an easy way to keep things separate, and that things that get soggy. Also, toasting your bread beforehand before assembling sandwiches can be helpful. Creating meals that are deconstructed so that you're almost making like your homemade Lunchable is another easy way to make a balanced lunch. And then using leftovers in a thermos is also helpful. And finally, taking advantage of school lunch options can keep things very simple. So working with your food service department in school to make sure that they are able to meet the nutritional needs of the dual diagnosis is important. And that brings us to some important concepts about educating our school teams as well. And sometimes they just need a little help. This is just one example of a school lunch that was provided for a field trip to one of our patients, and that had the dual diagnosis. And you can see it was a gluten-free bagel, Lucky Charms, a gluten-free juice box, dried cranberries, and a sugary yogurt. And mom texted, us with like her double-digit upward arrow from her Dexcom as an example of what happened, and it didn't need to happen. So just educating the schools in terms of ways that they can provide a balanced gluten-free meal that is also appropriate for type 1 diabetes is important. These are just some practical ways to accommodate gluten-free foods at school. And so just serving naturally gluten-free meals, fresh fruits and vegetables being included, having gluten-free bread for sandwiches or rolls or buns, using cornstarch to fry things, ensuring that the fryer is dedicated so there's no risk of cross contact for French fries, corn tortillas for tacos, ordering pizza from a vendor that has gluten-free options, checking soy sauce that it's gluten-free, offering veggie chips or potato chips or corn chips, squeeze bottles for condiments, and using a food service supplier that offers many gluten-free options. We also want to talk a little about a 504. It's important to have a 504 in place for both diagnoses so that it just keeps cross contact from happening, especially for younger kids. We also want to make sure that we're providing access to safe alternatives so that our patients with a dual diagnosis have the same access to things that student peers have access to, prevents students from being penalized for missing school, and it thinks about those things like field trips and special events. We also want to make sure that we're understanding barriers to preparing lower glycemic gluten-free meals and foods. So first off, limited access. So limited access to gluten-free ingredients can make cooking balanced meals a challenge. You need those gluten-free ingredients to make gluten-free recipes work. And we also know that gluten-free foods can be much more expensive than their gluten-containing counterparts. And during COVID-19 pandemic, 1 in 10 households with a child on a gluten-free diet ate gluten due to limited gluten-free food availability. So screening for food insecurity in clinics is important, and then working with your multidisciplinary team is also very important and helpful to come up with ways to provide individual options that can really improve that access to gluten-free food. Also, there's a limited knowledge of healthful gluten-free recipes and cooking techniques that can create barriers. And cooking gluten-free recipes can be really scary to some people, and it's just different than cooking recipes that have gluten in them. So understanding, like today's culinary class, how to cook gluten-free recipes is very helpful to improve access. Also, limited acceptance of recipes that have been modified to be gluten-free is a barrier, because sometimes gluten-free recipes just don't taste the same as things that had gluten in them. And then finally, ingredients just don't seem to sometimes last as long because a lot of gluten-free foods are just in smaller packages than foods that contain gluten. So the benefits of having culinary medicine and doing these cooking classes is, first off, it provides gluten-free recipes that use ingredients which are easy to access and also can be geared to be lower in sugar for our type 1 diabetes patients that have celiac disease. Also, nutrition information is provided so you know your carb count amounts. Indirect nutrition education is also embedded through the classes to increase nutrition knowledge. Thrifty ways to stretch food ingredients can be taught, and instruction on just how to do different preparatory methods and use different kitchen tools can be included, and it really can provide an open forum for families to ask questions. I'm just including some resources here from the Celiac Disease Foundation website that's very helpful for the dual diagnosis. There's a diabetes meal plan, which includes meal and snack ideas for multiple days. There's also the Halloween candy list that's available. And I also included the combination candy list that also includes carb amounts that's through the Celiac Kids Connection from Boston Children's Hospital. And these are my resources and references. All right.
Great, thank you. So just in the interest of time, I'm going to get right into the cooking demonstration portion of this and the recipe. So can you see my screen, Sharon? Can you let me know? Oh, you're unmuted, sorry.
I can see your screen.
Okay,
Yeah.
perfect. Thank you. All right. So here is a link to the recipe. We're going to be sharing an Italian pan-seared chicken taco recipe. Here is a QR code. I'll just give you a few seconds to scan that, but we will be sharing it after the presentation. Okay, and then I will go right into the video. For your reference, we included the nutrition facts on the side, just so you can kind of have an understanding of the macronutrients and the fiber specifically.
Welcome to the kitchen. Today we are making one of my favorite recipes that is packed with protein and fiber and great for people living with celiac disease and type 1 diabetes. It's a play on that famous, trendy online recipe for hamburger tacos, but today we're going to do it with pan-seared chicken, top it with a delicious Italian salad, and use tortillas that are made from almond flour. So again, they're packed with protein and fiber and great for the dual diagnosis. To start out, we're going to make a homemade Italian dressing. It looks like I have a ton of ingredients on the counter here, and it is a lot. We have some white vinegar, red wine vinegar, olive oil, water, Parmesan, garlic, salt, sugar, ground mustard, oregano, and dried red pepper flakes. But the good news is it's only going to take us a few seconds to make this dressing if you have a food processor. So I'm using the pureeing attachment for my food processor, and I'm going to combine all of the ingredients right inside. So see, it only took a few seconds to put everything into my little blender here. I'm going to go ahead and close up the top. You're probably thinking that this looks like a very full blender compared to the instructions on the recipe you were given. My family loves this dressing so much that I always double or triple the recipe so that I can keep it in the refrigerator and use it all week. So that's why we have a double recipe in this container right now. So we're going to go ahead and puree it all up. It's that easy to make homemade salad dressing that has all great ingredients in it for you. I'm going to put this in the refrigerator to chill while we make the rest of our pan-seared Italian chicken salad tacos. Now we're going to make the filling for the tacos. This is just simple ground chicken that I got at the grocery store. I'm going to add a little bit of garlic salt and some onion powder to it, and then some freshly chopped parsley. Now, this is so easy to make. You can do it on busy weeknights or make them for a dinner party, and they're that delicious you can have them any night of the week. So I'm just going to use my fingers to go ahead and mash this all together into a mixture. You could also add a little bit of Parmesan cheese if you wanted to the chicken mixture, or you can top it with cheese. Today, I'm going to top it with a slice of Swiss cheese, so I did not add any cheese to the chicken mixture. So that's all we got to do. Your chicken is ready to go. So now I'm very carefully, I did not touch the chicken with this hand. I'm going to pick up my baking sheet that I have lined with foil. I'm going to start out with 4 of my almond flour tortillas and just lay them out here nicely on the tray. With my already dirty hand, I'm going to take just a fistful of the chicken. You don't really have to measure this part unless you want to. And I'm just going to press it down onto each of the tortillas. I'm leaving just a slight border on the tortillas so that we have a place to grab them once they're all cooked. So now to cook these. We are going to head over as soon as I wash my hand to my griddle pan on my stove. But you could also do this if it's nice weather on the grill in the backyard. We love cooking these on the grill outside. They're a perfect alternative to a barbecue if you don't want to do traditional burgers and hot dogs. So you can pick, it doesn't matter as long as you have a heat source underneath them. So I'm going to wash my hands and we'll get to cooking. Place the tacos chicken side down onto your grill pan and cook for about 4 to 5 minutes until the chicken is cooked through and no longer pink. You'll repeat this with all of your tacos. Almond flour tortillas are an excellent option for people with a dual diagnosis of celiac disease and type 1 diabetes. Not only are they naturally gluten-free, making them safe for us with celiac disease, but they also offer additional benefits for blood sugar management. Almond flour is low in carbohydrates and rich in healthy fats, fiber, and protein. This combination helps to prevent spikes in blood sugar, which is particularly important for people with diabetes who need to manage their blood glucose levels successfully. Compared to traditional corn or flour tortillas, almond flour tortillas have a lower glycemic index. This means they digest more slowly, helping to provide a more gradual release of energy and reducing the risk of post-meal blood sugar spikes. Plus, they're packed with nutrients like vitamin E and magnesium, adding an extra boost of nutrition to your meal. When the chicken is fully cooked, flip them over and toast the outside of the almond flour tortilla lightly, about 1 minute. But don't overdo it because you want them to be able to easily fold up to take a bite. Here we have our salad bowl. We have some butter lettuce and some cucumbers. You can add whatever veggies you want to this. Avocado, tomatoes, onions, whatever veggies you like can go into this salad. There's no right or wrong. So we got our dressing out of the fridge. Gonna just give it a little shake to mix it all up and go ahead and top our salad. Then just toss it together and it's ready to go. Let's grab those tacos off the stove. And now assembly is so simple. Just take your salad and top it on top of your tacos. Everyone can do this themselves at the table, or you can do it prior to and serve it. And then it's absolutely delicious. I can't even wait to take a bite. These are amazing.
Great, thank you. And that was our Director of Health Communications and Community Education, and this Vanessa Weisbrod. So thank you, Vanessa, for that. Okay,
Welcome.
so now we're going to start the Q&A. I do want to leave this QR code up so that everyone can learn about how to get their CEUs. We have a lot of questions that came in, so give me 1 second to get it up. All right, and there was one question that was submitted ahead of the webinar that I want to start with. I think it's a question for both of the presenters, and so this is a parent of someone who has type 1 diabetes and celiac teenager. The celiac diagnosis came 3 to 4 months after the type 1 diabetes diagnosis. We never had a follow-up with the gastroenterologist, but this person said that doing their own research, they discovered that celiac patients should have a yearly blood test to test for gluten levels, which is the antibody test. So they said they've been very careful about reading food labels and making sure that everything their son eats is gluten-free, and they rarely eat out, and they always check the menu ahead and talk to the server, all the things we tell people to do. However, the levels were still high and they're very discouraged. So they want to know specifically what can they do to help their son. And then they've also asked for a script for probiotics and vitamin D testing, but was told it was not necessary. So they want some clarification on that.
Want me to take the first stab at it, Sharon? And sorry, how long has it been since celiac disease diagnosis now?
So let me just pull it up. Since 2020.
Okay, so about 4 years. There is one in the chat that is similar in some ways to this one too. The TTG tests are a little bit challenging because they're good for kind of giving indication that somebody might have celiac disease, but they're really not great at something that we trend over time and kind of use to measure adherence or how well you're doing with the gluten-free diet. So it's something we do. We all follow these tests over time. And in most people, they start high and, over 1 to 2 years, they go down and then normalize. And so that's the trend for most people, but it's not uncommon that we'll see a situation like this where your levels, may go down, but just never normalize. And it can be really frustrating for families who are already working really hard to avoid all gluten and to feel, disheartened that maybe they're sneakily getting gluten in. This is a situation where I think Sharon would agree it's really important to meet one-on-one with a dietitian specializing in celiac disease, because sometimes they will kind of go through things with you and find a sneaky way that gluten is getting in, and that could potentially cause this. Another thing that can happen, and this is almost exclusively in adult patients with celiac disease, but you can get a refractory celiac disease where even though you are doing a good job following the gluten-free diet, you just aren't responding the way that you should with having healing of your villi and normalization of that TTG. So this is something definitely where you want to talk to your GI doctor and say, hey, what do we do? This is hard and frustrating. Where do we go from here? In addition to talking to the dietitian, often a next step would be doing a scope again to look for damage. And I will say that in many, if not most cases where I have this happen, and somebody's TTG is still a little bit positive after 3 years, 4 years, 5 years of gluten-free diet, we can't find any hidden source of gluten. Almost always we do the scope and it's normal. Their villi are healed. They're doing a great job on the gluten-free diet. And it's just that our test isn't awesome. And so I think that's a big possibility in a lot of cases. Another thing is other things can make TTG go positive too. A virus can make it positive. If you have another autoimmune disease, that can make it positive. And so that is another sort of challenge here, where it's as if like we saw somebody and their TTG started high and it was tracking down over time. That's another one scenario. But if we, did it once and it was really high, and then 4 years later we did it a second time and it's still high, but we kind of don't know that middle part, it makes it a little more challenging. So really tough situation, and one that we do see not infrequently. And I think the best places to start are really with your dietitian and doctor, your GI doctor. And sometimes if it's a GI doctor who does a lot of general GI, but maybe not necessarily a lot of celiac disease, that can be a time that maybe you will want to see a celiac center or someone with a little bit more expertise if things are sort of not going the usual way. I do agree, and the data suggest that we should check vitamin D levels in patients with celiac disease, and typically yearly is what I do. There's good data for doing a ferritin or an iron storage level as well. Not really great data in doing other nutrition labs like vitamin B12 or folic acid, unless there's a specific reason with symptoms or things we see on the blood test. But in general, yes, even in a patient who their TTG normalizes, they're doing great on the gluten-free diet, I do routinely do labs. But this is an area that there may be a little bit of different practice style kind of thing. Now, with a probiotic question, that's a little bit different and tricky. So probiotics are basically giving good bacteria. And the thought is that a lot of different conditions, including celiac disease, type 1 diabetes, asthma, autism, I mean, probably many, many conditions, or if not all of them, are affected by your microbiome, which is the good and bad bacteria, viruses, fungi that are in all of our bodies, mostly in your GI tract. And that changes in this balance of your microbiome can lead to different disease states. So the idea of probiotics is giving more good bacteria to kind of shift the balance over. And the tricky thing of probiotics is that right now, you look in the probiotic aisle and it's very overwhelming, right? There's about 1 million different kinds. There's the fridge ones, there's different versions. They all seem very different. I think they're less different from each other than it seems from the packaging. And in the future, there's a lot more research being done about the microbiome, specific disease states. I think in the future, quite likely, we'll say, hey, you were diagnosed with celiac disease, take this specific probiotic with these specific strains. In the future, I think we're also going to have a better mechanism for giving probiotics, because right now, it says however many billions of colonies, but a lot of it is actually just getting pooped out. Like it isn't great at sticking in your GI tract. So generally what I tell patients is that very, 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 very rarely could probiotics be harmful. They may or may not be helpful. They are expensive. And so it's reasonable in some situations to try, in many situations, but I don't ever want people feeling like they have to stay on this probiotic if it's not helpful and kind of a financial burden. So I don't know, Sharon, if you have anything to add.
Yeah, I agree. I mean, I think that sometimes a probiotic can cost $100 for a month's supply, and that's like a lot of money, right? And so, so you might try it for a month and then and see like what happens when you don't continue it. And also, if a child's on different circumstances, like on a lot of antibiotics, maybe that's a time to think about it too, but then not long term. I agree that it probably can't hurt, but the jury's out on how much it can help now. But with more research, I think also and more changes in products. I think, again, it will be more targeted and more effective. And then in terms of just meeting with the dietitian, I think that, again, this is a unique case when we have this elevated TTG for 4 years, but and it sounds like the family's doing a great job. But again, meeting with a dietitian can be really helpful to just ensure adherence is being met and finding out whether there's tricky little things that you might not think about that just have gluten in them. So, yeah.
All right, I'm just going to do one more question in the interest of time. Are spices made in a factory that also uses gluten okay, or must it say gluten-free? For example, garlic salt, they can only get it in a factory that also uses gluten in the facility.
That's a great question. I think that first off, there's some companies that list gluten-free right on the spices. I'm not sure I can say the name brands right now, but definitely you can find spices that say gluten-free on them. When it comes down to like spice mixtures, sometimes mixtures include an anti-clumping agent that typically might be cellulose, but it might be wheat starch. So that should really mean that you're checking your labels carefully. But also practical kind of things to think about. So if you're using a 1/4 teaspoon of garlic salt in a recipe that makes 12 servings, and the possible contamination from a factory that may include gluten somewhere else is in there, the likelihood of you getting exposed to something in that small amount in the whole recipe is probably pretty unlikely. So, so I think that's another thing to think about. It's kind of the same thing about lipstick. Like, how many tubes of lipstick would you have to eat to actually get gluten, you know? So, yeah.
Yeah, great. Okay, thank you, everyone. Thank you for staying on a few minutes longer. I shared the recipe link in the chat, and the recording of this will be available shortly after the webinar on the Celiac Disease Foundation YouTube. So have a great rest of your day, anyone, and thank you for joining.